Hi, greetings everyone. Today we are going to learn about sleep terror disorder and elimination disorders, especially Encopresis and Enuresis in case of pediatric patients. This is another important topic in psychiatry and related conditions in which many questions can come, especially objective questions in both the medical as well as nursing examinations. So yes, this presentation covers most of the topic from first aid in USMLE preparation and also from Saunders in nursing preparations. If you feel that you can speed up the things, you can increase the speed in YouTube, and so that you can just get a comprehensive knowledge in a bit faster. Okay, so yes, now here I will be talking about, as I said earlier, sleep disorders. In sleep disorders, it will be a sleep terror disorder. Okay, and similarly, we'll study about elimination disorder, that is Enuresis and Encopresis, and finally the Narcolepsy. Okay, now moving on, what is sleep terror disorder? In sleep terror disorder, especially we are talking about a phase in stage N3 non-REM sleep. Okay, so this is a slow wave sleep, also called as deep sleep, also called as stage 3 non-REM sleep. In this phase, the children often experiences inconsolable terror with screaming. So while they will be sleeping at night, when they are in the stage N3 non-REM sleep, also called as slow wave sleep or deep sleep, they get the dream, and on that dream they fear, they go under terror, they scream, and that often happens during the middle of the night. And they are inconsolable. That means even if the parents try to console them, they won't be consoled. Okay, and yes, here in this case, the one thing is that the person or the baby or the children, they don't have the memory of what really happened in the morning. Okay, so although they went through that phase, but they don't have the memory of that. So why does this happen? So what are the triggers for this? So the triggers can be any emotional distress the child has been facing. Okay, so it can be physical stressors like fever or the recent sleep deprivation in the case of child. So any of these things can lead to sleep terror disorder in case of children. Yes, and this is often self-limited, and so when the child grows, this sleep terror often subsides on its own. Now, while talking about sleep disorders, we talked about sleep terror, but we'll also like to compare it with nightmares. Okay, so as I said, sleep terror disorder, it occurs in slow wave cycle of sleep or non-REM sleep, stage N3 of non-REM sleep, whereas nightmares, it occurs during REM sleep. So and in nightmares, unlike in sleep terrors where there was no memory in the morning, whereas in the nightmares, the children often has the memory, they remember. Okay, so they remember the scary dream. So that's another difference. And in sleep terrors, the child cannot be consoled. That means even though the parents try to console, they want to console, but in nightmares, the child can be consoled. And yes, they have the memory of the dreams. Okay, whereas in sleep terror, there is no any memory. So yes, this both sleep disorders, either sleep terror or nightmares, they both occur when the children is sleeping, but especially sleep terror disorder, it occurs in the middle of the night, whereas nightmares can occur during early morning, and sleep terror disorders occurs in non-REM sleep, stage N3 non-REM sleep or slow wave sleep, whereas nightmares occurs during REM sleep. So in nightmares, there is a memory of what has happened. The child can recollect the dream, whereas in sleep terror, the child cannot recollect the dream. And in sleep terror, the child will be crying, screaming, and can't be consoled. Whereas in nightmares, the child can be consoled. Now, talking about elimination disorders, we here like to talk about enuresis and encopresis. Okay, enuresis is inappropriate urination and encopresis is inappropriate defecation. So when we say enuresis, there is a certain criteria. So when the child, especially less than 5 years, the child must be, I mean, up to 5 years old, it's common for the children to bedwet, okay? But even after 5 years, if the child is still urinating in the bed, then at that time we may think of enuresis. But for that, apart from the age criteria that the child is 5 years or more, and the other criteria must be met, like the children must do bedwetting at least 2 times per week for at least 3 months. So at least 2 times per week for at least 3 months by any children who is 5 years and older of bedwetting. And then in this case we say that the child has met the criteria for enuresis. And yes, often it's yeah, there was not any other organic causes for this. And when you go through the management of enuresis, first line is always the behavioral modifications. So now the child is already 5 years, we can teach them, ask them for scheduled boarding intervals, don't give them drinks or water, just be I mean, you may give a little but not too much, just before sleep. And you can always train them bladder training exercises, also positive reinforcement strategies, that if you don't bedwet tonight, you will be given gift tomorrow or chocolate tomorrow, something like that. So this is the first line behavioral modification. So with the behavioral changes, modification strategies, the child may stop bedwetting. And remember, the child is more than 5 years old. And second line is, if this thing behavioral modification doesn't work, then we'll like to go with the bedwetting alarm. This is the second line of management. In this, the child at first gets a lot of, as soon as, I mean, when there is the, so in this phase, bedwetting alarm, so there is an alarm placed in the bed, and in this senses the moisture. So as soon as the baby leaks first few drops of the urine, the alarm sounds up, and then the baby gets up, and in this way gradually the baby stops wetting the bed, and it has high success rate. And if, despite of the first line behavioral modification and second line bedwetting alarm, if the person doesn't get there's a treated for enuresis, then we go with the pharmacotherapy, and that's desmopressin. With this, they use desmopressin more than imipramine. Previously we used to do imipramine, but we prefer desmopressin because yes, desmopressin is oral ADS analog, antidiuretic hormone analog, and we use desmopressin over imipramine because it has low risk of cardiac conduction abnormalities. Remember, imipramine is an antidepressant, and it has some cardiac conduction abnormalities as a side effect. So and even if you take desmopressin overdose, then there is less chance of fatalities as compared to imipramine. So because of less side effect profile, especially less cardiac conduction abnormalities, and obviously reduced toxicity in case of overdoses scenario. And so these things favoring desmopressin, we like to go with desmopressin rather than imipramine. Now we like to go with the Encopresis. So Encopresis, it's again a condition in which the children here is 4 years old. Okay, the children must be at least 4 years old, not 5. It's 4 years old and must have at least 1 episode per month, not per week, not 2 episodes per week, rather 1 episode per month for at least 3 months. If the baby is at least 4 years old, or let's say 4 years old and above, if he defecates in this bed for at least 1 episode per month for 3 months, at least 3 months, then we say he or she has met the Encopresis, and there must not be any other medical conditions or substance that is precipitating these things, Encopresis. Okay, so again, Encopresis is of two types, is with constipation and overflow of these two, and next is without constipation. and the most common is with constipation and overflow. So basically the children, they have a difficulty regulating their stool patterns, stool schedule. So because of that, the children often develop the chronic constipation. And when there is the chronic constipation, the stool will be blocking the rectum region, but however the liquid stool will leak around the impacted stool, and that leads to encopresis. And this is quite more common than the one in which there is no constipation and just the stool coming out of the rectum of the child. So yes, encopresis is of two type. Now again, encopresis also treatment strategies is behavioral therapy, and in which you do toilet training, positive reinforcement, and also if there's any underlying anxiety, you try to treat them. And next is while toilet training, you also must follow some specific time, schedule, and position so that the baby gets acquainted to it. And if this doesn't work out, and then since the most common type of encopresis is associated with constipation, so we may use laxatives and enema and polyethylene glycol for constipation. And also in diet, you can add fiber and hydration for the baby. And now we'd like to go with the narcolepsy. This is another important topic. So narcolepsy means excessive daytime sleepiness despite adequate nighttime sleep. So the person will feel that he or she has slept abundantly. So he, when waking up from the sleep early in the morning, he or she feels like they have rested well, but despite of that, they feel excessive daytime sleepiness, and this is called as narcolepsy. And it's often recurrent. And in narcolepsy, the person will have rapid onset and overwhelming sleepiness. He cannot control the sleepiness, and this occurs at least 3 times per week for a minimum of 3 months. Okay, so this criteria has to be met. And the underlying pathophysiology is that there will be decreased OREXIN, that's hypocretin, in lateral hypothalamus of the individual. And yes, because of this, there will be dysregulated sleep-wake cycles, and that leads to narcolepsy. Narcolepsy is classically associated with 4 different things, and that is hypnagogic hallucinations. So the hallucination, either visual, auditory, or tactile, that the person experiences before going to bed, that's hypnagogic hallucinations. Sometimes he has hypnopompic hallucinations. That means they have similar features, hallucinations that gets developed when the person wakes up in the morning, and that's his hypnopompic hallucinations. Similarly, there will be sleep paralysis. So sleep paralysis is like the person, when he wakes up in the morning, he cannot move or speak for, although temporarily. So this phenomenon is called as sleep paralysis. It occurs because of REM sleep intrusion at sleep onset. Okay, so it's again associated with REM sleep. And next is cataplexy. Cataplexy is sudden, this is important, okay, sudden bilateral loss of muscle tone, especially when there is extreme of emotion. So the person has narcolepsy, and during the daytime, if he is laughing, so if he has extreme of emotion, laughing, and then suddenly he feels like there is a bilateral loss of muscle tone in his body. So this is called as cataplexy. It also occurs because of decrease in OREXIN and loss of regulation of REM sleep phenomenon. So for the narcolepsy treatment, again, sleep schedule is important. Person has to sleep for at least 7 to 9 hours, and schedule naps. Here, so you can take schedule naps of, let's say, 15 to 20 minutes proactively before anticipated sleepiness. Okay, and good sleep hygiene, good sleep environment, decrease caffeine in the night, and excessive exercise. Proper exercise is important. So the drugs necessary for the pharmacotherapy for narcolepsy is modafinil. Next is amphetamine. These are stimulants. And modafinil is quite common, and similarly we have solriamfetol and pitolisant. And sodium oxybate is another drug that is important. it's special because it's also improves the nighttime sleep consolidation, and which reduces daytime sleepiness. Okay. Yes, thank you.